So once again, welcome everyone. Thank you for joining us today. Before we get started, just a few quick housekeeping items I would like to mention. The slides and recording from today's webinar will be made available and sent to all participants. You may turn on closed captioning on the main Zoom toolbar labeled CC, Show Captions. If you experience any technical difficulties today, please notify me, Patrick Ahern, in the Q&A section. And your questions can be submitted into the Q&A window at any time and will be addressed upon completion of the presentation. So with that said, I'll hand things over to Sari Schumann to get us started.
Great. Thank you so much, Patrick, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Bridging Healthcare and Social Services for People Living with Dementia and Their Caregivers. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Chris Stockton of the Administration for Community Living will provide a brief welcome. Chris?
Good afternoon, everybody. Thank you all for taking time out of your busy days to accompany for this topic. And these wonderful, thank you for all the presenters taking time out of your day to present. With that being said, Sari, take it from there.
Great. Sure. Thank you so much. So today's panelists are Jill Sigliana, Dr. Steve Council, and Becky Kurtz, and our moderator today is Helen Lamont. I'll provide you with their bios and then we'll move into our panel discussion. Jill Sigliana is a leader and catalyst for positive change in the field of dementia care and serves as Executive Director of Memory Care Home Solutions, a nonprofit organization based in St. Louis, Missouri. Memory Care Home Solutions exists to improve dignity and quality of life for people living with dementia and their families by transforming evidence-based interventions into accessible healthcare solutions. With over 26 years of experience in acute and post-acute healthcare settings, Jill leads a dynamic team of professionals who push the boundaries of conventional approaches to pave the way for a more compassionate and effective future in the landscape of home and community-based dementia care. She holds a Master's of Science degree in Occupational Therapy from Washington University in St. Louis and currently leads the Dementia Community of Practice for the American Occupational Therapy Association. She has served as Project Director for multiple grants in the ACL Alzheimer's Dementia Programs Initiative. We also have with us today Dr. Steve Council, who is Professor of Medicine at Indiana University School of Medicine in Indianapolis, Indiana. Dr. Council was the founding director of the Indiana University Geriatrics Program and has served as president of the American Geriatric Society. He developed the Geriatric Resources for Assessment and Care of Elders model of geriatric care management, which has shown to improve outcomes and reduce acute care utilization in older adults with complex needs. Dr. Council was the project director of Indiana University's ACL Alzheimer's Dementia Programs Initiative Dementia Care Grant and continues to partner with Indiana's area agencies on aging to provide the ABC community a telephonically administered version of the aging brain care model that reduces caregiver stress and improves the quality of life for people living with dementia. As Medical Director for Indiana Family and Social Services Administration's Bureau of Better Aging, Dr. Council is working to improve integration of healthcare and social services for older adults duly eligible for Medicare and Medicaid. Our final panelist today is Becky Kurtz, who is passionate about supporting policies and services that maximize well-being as we and our communities grow older. Since 2017, she has directed the Area Agency on Aging within the Atlanta Regional Commission, where she and her team administer services and prepare for the rapidly aging Metro Atlanta region. She shares her expertise with students of the Aging Policy and Services class as adjunct professor at Georgia State University's Gerontology Institute. Much of Ms. Kurtz's career has focused on protecting the rights and well-being of long-term care facility residents as the National Director of the Office of Long-Term Care Ombudsman Programs within the United States Administration for Community Living, as Georgia's State Long-Term Care Ombudsman, and as attorney with the Atlanta Legal Aid Society. Ms. Kurtz is a graduate of Columbia University School of Law and Emory and Henry College in Virginia. Finally, Helen Lamont will moderate today. She is the Director of the Division of Disability and Aging Policy and the Acting Associate Deputy Assistant Secretary of the Office of Behavioral Health, Disability, and Aging Policy. She leads the implementation of the National Alzheimer's Project Act coordinating both the Advisory Council on Alzheimer's Research, Care, and Services and annual updates to the National Plan to address Alzheimer's disease. In addition to dementia, Helen has expertise in caregiving, elder justice, and adult maltreatment and disability and aging data. She joined the Assistant Secretary for Planning and Evaluation in 2007 and has a PhD in Aging Studies from the University of South Florida and a Bachelor of Science in Human Development from Duke University. At this time, I will turn the session over to Helen Lamont to begin. Helen?
Thank you so much, Sarah, and good afternoon, everyone. It's great to be with you here today. Back in 2012, HHS created the first ever national plan to address Alzheimer's disease, which has been a call to action across the federal government on research to prevent and treat dementia and actions that we're taking now to support people with dementia and their caregivers. We were often asked, especially in those early days, why focus on Alzheimer's disease? Why not other diseases? And the reason was simple. This population has complex clinical care needs and extensive needs for long-term services and supports. Assisting the caregiver is essential. Dementia impacts the person with the disease and their entire family and ecosystem. Both units need to be supported through the course of the disease. And this population essentially is the most vulnerable of the most vulnerable. Over the last 15 years, we've made a lot of progress. In partnership with states and local governments, ACL has invested millions of dollars in improving long-term services and supports for this population and supporting their caregivers. And thanks to the tireless work of many people on this webinar, we've seen great improvements in what our communities are doing. However, we know that additional support and programs are still needed. In order to truly meet the long-term care needs of people living with dementia, services need to be coordinated with their health care. And conversely, in order to meet the healthcare needs of this population, that care needs to be coordinated with services that they receive in the community and in partnership with their caregivers. There are a number of efforts underway across the country to do just this. In 2024, CMS's Innovation Center announced their guide model, which is testing whether more coordinated care can improve outcomes and delay nursing home placement for this population. We're excited to learn from Guide about whether this care coordination does improve those outcomes. However, it's equally important for us to learn how to do this coordination, how to make this work on the ground. Back in 2024, after the guide model was announced, our office worked with ACL to do a study of how to bridge healthcare with social services for people living with dementia and their caregivers. You'll be able to access this report at the end of the presentation. We'll have a QR code for you. And to summarize, what we found was that successful models include early identification of dementia symptoms and referral for a full workup and evaluation, individualized care plans, regular check-ins, and an ongoing assessment of whether those care plans need to be updated to meet the changing needs of the patient, tailored referrals to relevant resources, warm handoffs, caregiver training, education and support, and medication management. However, we also found a number of challenges to doing these programs. First is getting buy-in across the organizations. Not everyone appreciates the needs of this population or what the value add is of coordinating across systems. Relatedly, both the healthcare and social services systems face workforce challenges. There's a shortage of workers not only to do this work, but who have the right knowledge and skills to meet the specific needs of this population. And perhaps the greatest challenges are those that come from systemic differences. That is, the differences between how the two systems are set up and how they are funded. Many community-based providers on this call are likely funded through the Older Americans Act, which primarily funds grants to states, communities, and community-based organizations. Healthcare for most of the 65-plus population in this country is financed through Medicare. Medicare reimburses providers for care provided to those Medicare beneficiaries. This is usually done through either fee-for-service, where a healthcare provider gets paid a fee for each service they provide, or through managed care, where a plan gets a fixed per member per month amount to pay for all of the care for that beneficiary. There are other system differences that are due to these funding sources. For example, the data that community-based providers collect to report on their grant progress is very different from the data that healthcare providers collect in order to get reimbursement or to report quality measures to CMS. Most healthcare providers use electronic health records, or EHRs, which are rich sources of information and a conduit to coordination. But often community-based providers don't have these systems or can't access the EHRs for the people that they serve. Today, we're here to talk about these challenges and to learn not from some researchers at HHS, but from the experts, the people in the field who have done this work, about how they've overcome these challenges and where you can learn from the successes they've had. With all of that said, I'd like to finally turn to our panel. We'll start with Becky. Becky, can you tell us about the needs of people living with dementia and their caregivers from your perspective?
Yeah, thank you, Helen. And thanks for that great intro. That really summed up a lot of the issues that we're going to be discussing. So first of all, let me just say I'm coming to this from the perspective of an area agency on aging. Helen mentioned the Older Americans Act, and it sets up a network of area agencies on aging across the country. And with that role, one of the things we do is we provide information referral in a no wrong door kind of way through the Aging and Disability Resource Connection. We also happened to, AAA's happened to have the Title III funding, which is the National Caregiver Support Service as part of the Older Americans Act. So through those kinds of programs and opportunities, we hear from lots and lots of individuals living with dementia as well as their caregivers, tens of thousands every year in just Metro Atlanta area. And what we hear is as varied as the individuals and as varied as the families that support them. So it's so critical to start off with a person-centered or a family-centered approach. Not only what do you need, but what are your goals and how do we help you be supported in reaching those goals? It's a long and intense caregiver experience. And so those needs and those goals are actually going to change over time. It may start off with needing information about the disease trajectory and what that means for how our family is going to adapt down the road. And it may be planning for the future. Where are we going to live? How do we make this work? But eventually it might get more to safety needs. How do we intervene when there are behavioral symptoms and other challenges that come up that weren't early in the disease progression? So I think it's really important for those of us in the social care world to be able to be flexible in the services we provide, as well as flexible in hearing what the needs are as they change over time.
Thanks, Becky. And now we'd like to hear from Dr. Council. From your perspective, what are the needs from the healthcare perspective? What are the services required to meet the needs of people living with dementia? And how is it important from your perspective to link social services and healthcare for this population?
Yes, well, thanks so much for the opportunity to be a panelist today. And I like how Becky at least gave her perspective, and I'll do the same here. I'm coming from leading a large academic geriatrics program in 3 different health systems, IU Health and Eskenazi, which is our public safety net hospital, and a large Indianapolis VA medical center, and now working more with the state of Indiana around duals. But in my experience with dementia, and actually with most older adults with geriatric conditions, we really need to integrate both medical care and social services. And so from the medical side, we need a comprehensive assessment that can help us, in the case of dementia, certainly assess cognition and functional status to inform an individualized care plan. We need to carefully manage coexisting conditions. People with dementia oftentimes have more chronic illnesses than those without dementia, such as high blood pressure or COPD or heart disease. Medications is a big deal on the healthcare side. Oversight of medications, avoiding medications that may make cognition worse, including over-the-counter medications that people may take, and simplifying the medication regimen as much as possible to minimize the cognitive, burden or complexity of adhering to a medication regimen. Sensory screening, so attention to hearing and vision. So you want to optimize those other important functions if your cognition is compromised. And a couple other things that are especially important: mobility, attention to mobility and falls prevention, caregiver education and support. So when we're caring for someone with dementia, it's really a dyad. We're really looking at the pair, at least one. If they're not able to do everything for themselves, who is it that's helping them? And then to really help support and help that person get what they need. And finally, coordination of care. This is another big one that is especially difficult in a very fragmented health system so coordination between primary care and specialists for those other conditions perhaps, but also a coordination of care between settings. So especially if they go to a hospital and hospital back to home or to a skilled nursing facility, ED visits, some kind of continuity and coordination with medications and their goals of care and advanced directives are all really important. So why is it important to link healthcare services with social services? Well, as I mentioned at the start, you really can't provide standard of care for an older adult with geriatric conditions like dementia without paying attention to both their medical and social services and supports and needs. And dementia in particular, impacts, memory and behavior and physical functioning, all of which have big implications, for day-to-day living. And so social supports, caregivers, and things are critical to optimizing their quality of life. We also know that better integrated care can perhaps prevent or delay nursing home placement, which many people desire to stay in the community as long as possible, and certainly avoid potentially an emergency department visit or hospital stay that can be rather traumatic for someone in particular with dementia. So our goal would be to integrate both medical care and social services so everyone's working together toward that common goal of optimizing the quality of life for both the person living with dementia and their caregiver.
Thank you. We teased at the beginning that all three of you have experience doing this work in the community. So now I'd like to turn over to Jill and then go through all three of our panelists. What examples do you have of how your communities have bridged healthcare and social services systems for this population?
Sure, and to add another perspective to the mix, I'm representing an independent community-based organization who does partner with both AAAs and also healthcare systems and academic partners. So kind of in the middle of the two perspectives represented by Dr. Council and Becky. But I can share our organization's story of bridging these worlds. Because at Memory Care Home Solutions, we saw that families living with dementia were often forced to navigate two completely separate worlds, healthcare with primary care, neurology, medications, diagnoses, and on the other side, this range of options and community supports that actually help people live well in the day-to-day. That might include things like caregiver education, safety planning, behavioral symptom management, respite, support groups. So, and we saw that families were being asked to connect all of those dots themselves, which is nearly impossible to do when you're in the midst of one of the most stressful times of your life. So our organization made a really intentional decision to stop operating solely as a traditional social service organization and instead build a more integrated model that we did not see in our community. And I will say for a nonprofit, this was an enormous decision for us. And we made it at a very strategic level with a lot of involvement from our board of directors because we knew it would be a heavy lift of both time and resources. But we did decide to enroll as a Medicare provider, and we contracted with Medicare Advantage and commercial plans so that we could offer clinical services, including occupational therapy and care partner counseling, alongside some things that were more social service, like dementia navigation and caregiver support. So today, a family can come to us, one organization, and access both healthcare and social supports, but all through a dementia-specific lens. So whether a family works with a dementia navigator, an occupational therapist, or a social worker, any of our staff can serve as a bridge back to their healthcare team by sharing information, identifying concerns early, and helping to ensure that everyone is caring for a family that is moving in the same direction. And we also learned that bridging healthcare and social services is about much more than just bi-directional referrals. It's about creating a true coordinated ecosystem where everyone talks and families experience one connected system rather than what feels like a series of very disconnected programs. And I would say that comes down to an emphasis on things that we can all do better, which is coordination of care and relationships with families sustained over time.
Thanks, Jill. That's a really important point about the real integration of the two systems and not just referring back and forth. Dr. Council, will you tell us about your experience in your community?
Sure. So some examples that we've worked with is, as you've pointed out, it is really challenging, and starting up new programs in a big city, especially around dementia, where the public knowledge and awareness and even healthcare professional knowledge and skills in the area is not where we would like it to be. So working with the primary care practice, for example, we would have a simple flyer that had both bullet points about the Area Agency on Aging and the Alzheimer's Association, and bullets on what they should think about for making a referral or connecting their patient with those organizations, and then one single number. And then ideally, on top of that, having a designated or even an embedded staff person from the local area agency on aging, or it could be virtual, but a designated person that can consistently respond to that particular clinic and provide some continuity, as a referral resource. And then, so that's the first piece, sort of that simple flyer and referral to a designated person. But then you can grow on that a coordination of care between mutual patients or clients. So once they are a client of the Area Agency on Aging, for example, you can coordinate services and supports between the primary care provider and the social services agency through that same designated person, at least. So there's sort of one-stop shopping. It makes it simple to coordinate care. That's two examples. And the third is that we have also at the state level, we've required the dual eligible special needs plans, the health plans, to actually identify their people with a diagnosis of dementia and make a referral to the Area Agency on Aging or Alzheimer's Association, just proactively, so that the person living with dementia and their caregiver would grow an awareness of what services and supports are out there. So basic, but got to start somewhere before getting to the ideal world where Jill is describing.
Thanks. And Becky,
Yeah.
what have you seen in Atlanta?
Well, those were both great examples from my co-panelists. We have over the years worked really hard to develop relationships, especially with the social services departments in healthcare providers and systems. So that has helped with bridging some of the referral challenges. But to Jill's very excellent point, it's not just a seamless referral. I mean, that's a challenge in and of itself, but it's a much more complex reality than only referrals. So in the last several years in Georgia, we have started a program. I say we, not we at the AAA level, but actually the state has funded Emory University for a Georgia Memory Net, which is a statewide system of early detection for dementia. And basically, primary care physicians refer to the Georgia Memory Net for the diagnosis piece. And then the folks at Georgia Memory Net, which are housed at various medical centers here in Atlanta, it's at our large public hospital, Grady Hospital. The folks there, when they're counseling the individual and the family about the diagnosis and about the medical issues, they at that time tell them about and make referrals to the Area Agency on Aging and to the Alzheimer's Association. And when we get that referral, to Dr. Counsel's point, we have a dedicated staff person that not only receives that referral for that continuity and that warm handoff, but also participates in a bi-monthly meeting with the Georgia Memory Care folks locally so that we can have good communication about what's going on. So, for example, when an individual hasn't come back for their follow-up appointment, and we look into what's happening with that family member or what's happening with the patient, we can learn, oh, they actually didn't know about the appointment, or they didn't have the transportation, or whatever the need was that helps enable them to actually follow through with the treatment plan. We're able to help bridge some of those needs for the patients. So that's been a really important approach that we've been taking in Georgia. We also, in each area agency on aging, we now have a dementia care specialist who also helps us with supporting that relationship with the Georgia Memory Net. So, and helps our network be more dementia capable. So we've got several different things going on, but I'd say that's one example of some integration and of some information sharing about patient situations that's absolutely critical across systems.
Thanks, Becky. And what I love about our panelists is that the impetus for this coordination started in 3 different locations. So it doesn't just have to be the community-based organizations starting. It doesn't have to be the healthcare. But in Georgia, you actually have the state step in and say, this is the type of system that we want. And that's amazing. So now I'd like to talk about the nitty-gritty. What were the challenges you all faced in doing this work, and how did you overcome them? And I don't know if that should be past tense or present tense. So what are the challenges you did face, and what are the ones you're facing now? We could just go in the same order, Jill.
Sure. And it's all of the above, past, present, future. There are lots of challenges. I think one of the biggest hurdles was that, we were trying to build a model that intentionally spans sectors, but the infrastructure for that doesn't really exist, and it still doesn't really exist. As a community-based organization, we do not have access to the electronic medical records used by the health systems in our region. So even after we created integrated services within our own organization, we still had to figure out how to stay connected with each family's broader healthcare team. And I think we all wish there was a magic platform, tool, a technology answer, but it really comes down to something much less glamorous, which is just lots of communication. And for us, that looks like, when a family begins service with us, we built out a workflow that includes sending a notification to their primary care provider and any specialty providers involved in their dementia care. Hey, Memory Care Home Solutions is supporting this family. Here are the things we'll be checking in with them on. Feel free to send them back to us, if they're bringing some of these issues to you. And then again, if they enter our occupational therapy clinical service line, we communicate that as well. We have, if we identify medication concerns, safety risks, changes in function, new health symptoms that require medical attention, we will proactively reach back out and communicate that to the healthcare team. It takes a lot of time for our staff, and we had to kind of give up on, we're a HIPAA covered entity. We're communicating with other HIPAA covered entities. So coordination of care is a perfectly reasonable and allowable thing to do, but sometimes providers aren't comfortable communicating back with you, with our organization. So we have to keep the family in that communication loop. So although it's not as seamless as EMR integration, it does help ensure that everyone, at least has access to the same information. I think the other challenge was more cultural, as the other panelists have alluded to, that healthcare systems and community organizations, besides having very different funding, speak different languages and operate on different timelines. So again, this is another unglamorous challenge, but it's about building trust, and that takes years. So we had to demonstrate that what we could bring to the table complements and does not compete with the healthcare system. And that communication helps build trust with healthcare providers. It was also very, like, this is something we didn't intend to encourage, but we got feedback and realized what a powerful tool this was. We asked families to share with their healthcare providers about the support they were receiving from our organization, because physicians are much more likely to refer when they heard directly from their own patients and caregivers that the services were helpful, practical, and reducing their stress at home. So that kind of trust building over time, it really helped foster two-way communication. When providers saw that families arrived more prepared for appointments, and the providers knew there was a trusted community partner helping reinforce a care plan, and that it was reducing calls to provider offices, because they knew that the families were accessing education and support outside of medical appointments, trust began to grow. So I think when providers hear positive feedback from families, when they see that the community organization communicates back proactively, and when fewer crises, to Dr. Counsel's point about, less time in emergency rooms and hospitalizations, trust begins to grow. But that is a time-intensive effort.
Thank you. Dr. Counsel.
Yes, those are some real pearls coming out of Jill there. So I'll maybe build on that, especially from the healthcare side. The limitations or challenges is again, limited knowledge and skills in dementia care, not realizing the importance of connecting with social services and the like. And then just the complicated workflow and processes of any kind of health system. It would just become so complex for the workers. And then the personnel really are challenged by limited time and few staff to be able to designate the time to make these connections and then to start to really coordinate care. So a lot of those things. So solutions, a brief, succinct training, over lunch or some designated time period when they're already together. So not adding things to their schedule, but piggybacking on to things with a leave behind simple flyer, not too much of an ask. And so making simple solutions like one number, when to call, a designated person that gets that kind of continuity that they can learn to trust and build trust that, hey, my patient's going to get what they need if I talk to so-and-so about it, and you work with them. And then designated staff on both sides. If you can get the commitment that, just out of the mission orientation of both sides, we want what's best for our patients and our clients to optimize quality of life and their health, that let's work together on these initial referrals, but building a relationship over time and seeing how we can better deliver in an ongoing way on our mutual goals and process improvement. So there's a lot of challenges to work through, and they can be as basic as just how do we identify who's already a client at the and at the site. So lots to work on, but I think finding a champion on both sides that can designate some time in a longitudinal manner to work together is really key.
Thanks. And I see everyone nodding. So I know these are shared experiences everyone is having, unfortunately. Becky, how about from your perspective?
So to add a couple of comments, one is I think that we sometimes have the challenge of assumptions. The social care side assumes things about the medical side, and the medical side assumes things about the social care side that may or may not be accurate. But in the same way that I don't expect that the staff at the Area Agency on Aging are going to understand the latest research on treatments, I don't expect that the medical side is going to understand the array of services and supports that are out there and that we might be able to provide. And I think sometimes there's an assumption that the medical care side has of knowing what we do and do not have. And I'll bet we have a lot more than is assumed in many cases. Having said that, one of our big challenges is, we haven't really talked about this in depth yet, is the financial underpinning of how we operate. And so while at the beginning, Helen did a great job of explaining how the Medicare and Medicaid pieces fund on the healthcare side, while there's some work being done to bridge that, on the social care side, traditionally, we've been grant funded. And that means when the funding's gone, and the waiting list happens. And so I know there's often a frustration on the medical side, and certainly for the client and the family, that a referral gets made to us and they find out that, oh, by the way, there are 1,800 people waiting for meals in my region right now. So how do we get through that waiting list problem and get solutions to folks right away? Sometimes it's a grant issue that there's not enough funding through grants. And sometimes it's an issue of workforce. We started talking about the workforce earlier too. Sometimes I can have the funding availability for something, but I can't get the workforce to get out there and provide that respite service. And so then the money goes unspent because we can't get the workforce in place. So it's a more complex problem than just money, but it's often a money flow issue as well. I will say that increasingly area agencies on aging are becoming, and other CBOs like Jill's, are becoming much more creative at finding solutions with other kinds of revenue, because the grant model is so limited and the demand is so much more than the capacity of most of our Older Americans Act and other federal and state grant funds.
Thanks, Becky. Now I'm going to ask you all about what advice you would give to an organization that's thinking about doing this type of work from your perspective. But Jill, I'm hoping that you can speak to the thread that Becky just started about the financing and what your organization chose to do and why and how it worked. And if you were in that position now, what advice you'd give to someone else?
Yeah, I mean, it was part of our strategic decision to take the step to offer some clinical services because we knew that would be, that's a fee for service revenue line and helped us become, not entirely, but somewhat less dependent on grants and philanthropy. And then back to Steve's point about working at the state level, we also, found opportunities to contract with the BOLD work, the building our largest dementia infrastructure work going on in our state. We found ways to contract with our geriatric workforce enhancement program to bolster some of the workforce lack of knowledge of dementia best practices. So it back to Becky's point about creativity. I mean, it takes all of these creative approaches, which then and all of it helps, but then you're also running, 5 or 6 business models at the same time, which is an administrative burden on your admin staff. So, none of these are perfect solutions, but they all help to diversify that funding mix that keeps this work going. So obviously we need better, more comprehensive funding solutions, but the creativity is essential, and partnerships. So from the financial sustainability point, that's what I would share from our experience. But I know you asked another question too, Helen. Did you want me to share practical tips?
Yeah,
Too?
what are practical tips? Sorry,
Okay.
I wanted you to tell us a little bit more about that part.
Yeah, no, it's a very great point. And that's why I love the topic of this panel, because it's so complicated that we need to share these experiences so people will know that, the work is hard, but it is possible with a lot of great leadership and coordinated work with partners. But I mean, and to that point, I mean, that's how we got to where we are, is we spent a lot of time listening. So you really have to listen to what your clients, your patients, your families, and your partners are telling you. And so we before we even talk about our programs, we ask partners, what challenges are you facing? Like, what are families calling you about between visits? Where are you struggling to find support? Because we also didn't want to duplicate anything our area agencies, agencies on aging were doing. We wanted to fill the voids, not duplicate any services. So collaboration for us became much easier when we positioned ourselves as part of the solution to problems that our partners were already trying to solve. And I would say another thing, and as Steve mentioned, but make referrals easy and communicate back. We put an online referral form, so people don't want to pick up the phone or make a fax. They can just go to a secure form and put information in that way. And it really is a no wrong way to make a referral. But one of our health systems was able to include memory care home solutions as a drop down in their EMR. So having a prompt for staff, which made an electronic referral and like an eFax out of Epic, which is the EMR most of our health systems use here, easier for staff. Again, it's got to be easy for staff. And I think something else that really helped us was creating opportunities to connect that are not tied to referrals. So we do, and this is again something that we get paid to do in part through a contract with our GWEP partners, but we offer professional education because we know we can't be the solution for everybody in our region who has dementia. We need the entire standard of care to improve. So we provide professional education that brings people together that are serving this population from lots of different standpoints and perspectives along the continuum of care. And it creates opportunities for us all to learn together. So when we're in the same room discussing evidence-based dementia care, we are building relationships and improving the system all at the same time. And the other thing that we aren't doing so much now, but was really helpful for our organization, we invest, and I don't mean monetarily, in champions within organizations. So for years, we would give awards to mission champions who were from community partner organizations who took that extra step and like really understood what families navigating dementia need. Because nobody in the healthcare or the social service field is ever acknowledged or celebrated for going above and beyond for their clients and patients. So if you can take the time to do that, to recognize the people who are going above and beyond, again, it creates a shared celebration about what is working in your community, and partnerships become stronger.
I love that. And you're 100% correct. Dr. Council, you as a champion in your health system for this, what practical advice would you give to other folks?
Well, I can be brief because I can be brief because Jill covered some of the most important. That's really where I was going to start. When advising an area agency on aging on how to better, maybe connect with their local health system, or physicians is to do that, identify an influential, healthcare leader or champion, someone who gets it, and realizes the importance of making that not only the connect and the referral, but working together in that integrated care model to optimize that person's health and quality of life. And then to start small and to start with people that you already are both taking care of and supporting. So whether it's around care transitions at the hospital or with a physician or primary care practice, identify those people that you're already both taking care of, but you don't know it. And you're not talking about it, and you're not communicating, and then start that kind of small group to gradually identify, well, how can we do better for those people that we already share in caring for and responsible for, and then gradually building that kind of trust and understanding of the value add, of working together and what services. Yeah, what healthcare has no idea what LTSS even stands for, or what the aging network is. They're viewing discharge either to a nursing facility or home and home with home health. That's pretty much, in a simplified way, what they are knowing about in terms of the long-term care arena outside a nursing home. So starting small, finding influential people who want to work together, that get it, and then gradually building that trust and added value view. And we've had the hospitals then actually support and pay for a full-time staff to be embedded in the primary care clinic or in the Center for Senior Health. That helps with discharge planning as well as outpatient consultation and connecting people with non-Medicaid home and community-based services. So, lots to do. Start small, go slow, build trust. That's really good.
Great advice. Becky?
I think that the point about having the dedicated person who can be kind of the bridge or the champion is really important, and it's really expensive. And if you're in a metro area like I am, where there are multiple healthcare providers, we can't afford to have designated folks for everyone that wants a dedicated person. I will say, I think it's ideal. And I think the level of communication we've been talking about and sharing of information is ideal. I also think it doesn't come for free. And so we've got to figure out ways to make that affordable for the Area Agency on Aging or the CBO to have that, as well as for the healthcare provider to have that. We do have some small models that where healthcare sector has paid for staff to be dedicated staff for them, and where we've got the expertise, but we can't afford to do that without some investment in that kind of model, which is really effective when it gets paid for and can happen. I wish we had the ability to do it with every healthcare entity, but we just don't. I'll add one more thing, because you all have made such great points about listening to partners, listening to the patients and the families. I was going to go that way, but since you did a good job on that, I'm going to add one more point that I hadn't heard, which is thinking creatively about technology. Whether that's technology to help the caregiver, whether that's assistive technology to help with activities of daily living for the patient, the client, whether it's technology because some people want to do self-service online and find out your resources for themselves and not have to talk to a person, but to have that technology partnered with human beings so that you never lose that human touch for people who want the human touch or need the human touch. So I do feel like there's a lot of opportunity for us to think in very practical ways of using technology to support our staff, to support the caregivers, and to support the patients, and to support that communication flow.
That's an excellent point, Becky. Just recognizing the multiple generations and the preferences for communication, for information seeking, not only on the caregiver family side, but also in the workforces that you all are engaging with. So thank you all so much. I've asked a lot of questions myself, and now I want to turn it over to our audience. Sarah, do we have questions in the Q&A that we could ask our panelists?
We do. So a question that came up, and actually I'm going to start with questions, but Patrick, can we just pop over to the slides quickly when we are, just so everyone can take a look at that while they're populating their questions. I just want to note before we start to take a look at this slide, take note that there are some funding opportunities available for ACL ADPI, states, communities, and tribal nations. We'll leave this up for a few minutes while we ask the first question. A question that came up, and I think I know the answer from all the panelists about this because it says, do you agree we should reach caregivers where they are? But can you talk a little bit about your response to that and then how we integrate that into the social supports and healthcare services we are providing to people living with dementia and their caregivers when the caregiver is not the patient or necessarily the client? If the person living with dementia is, how do we make sure we're reaching caregivers where they are in this model where we want to coordinate services? And Becky, you're off mute. Do you want to start first?
Well, that question could be interpreted a couple different ways. Like, is where they are physically, or where they are mentally, or where they are. But I'm gonna try to assume that is where they are physically, how to find them. And a lot of that is about our thinking strategically about our outreach as an area agency on aging. Are we communicating to various geographies as well as various ethnic and language speaking groups? So how do people find us? How do they find out about us? We have to be very proactive and creative in that. And one of the things we've found is a lot of that is through trusted partners. We need to be able to go to community groups or faith communities and have them be our partners because they know their communities better than we do. Even though we're local, we're not as hyper local as some of those partners are. And then in terms of where the caregivers are mentally, I think that starts with if they've found us, we have to meet them where they are in their family journey. That's all about listening to what their goals are and what they are telling us they need, and not us making assumptions about what services we have ready to go for them.
Great, thank you. Jill or Steve, do you want to add on to that at all?
I'll just say Becky's previous point about the different modalities of access is really important, because if people don't agree with or accept or are in denial about a dementia diagnosis, they won't want an intensive service to support caregivers. So you need to have that accessible education and some follow-up touch points so that when they do become more ready to engage, that they know there was a place in the community that they can re-engage with, because even within families, caregivers, we talk about like everybody has one caregiver, and that is, some people have no caregivers, some people have 5 caregivers, and those people aren't always on the same page of understanding or acceptance, and that's why you need print, video, self-serve education in addition to individualized support.
Or they don't even realize they're caregivers, or they don't see themselves as caregivers. So on the healthcare side, we're just really driving to the case that if you've got someone that needs help in their day-to-day activities, that there's got to be someone doing that, and to engage with that person and the importance of that, in the overall healthcare, of your patient. And secondly, I think also really talking to the person with dementia in this case, hopefully early on in the disease course, where they can identify who is their trusted, confidant, and it may not be their caregiver, but who would be, who they would be comfortable making decisions for them if they're unable to make decisions for themselves, in an emergency room or in some kind of a crisis, and that they share their long-term goals and what's important to them so they can help with decision making down the road. But the first is just identifying that, hey, this person must have a caregiver, what we're calling a caregiver, and let's identify them and see how we can support them.
I'll jump in and ask one. I mentioned at the beginning the guide model, which is a sort of first glimmer of a possible payment and policy change to support this type of work. Are any of you participating in guide, either fully as a guide provider or as a contractor relationship with a guide model?
Yes, two of our health systems have a guide program here in Indianapolis, IU Health and Eskenazi both. And I'll agree with you completely. That's, the beginning of that kind of integrated care. It's focused on dementia care, but it does really emphasize both the medical and the social supports, which is really in the right direction.
We're not currently in a contract with a guide provider, but have definitely had conversations both with local entities and national entities about that possibility. I think we're going to probably move in that direction. We're very excited about the concept of Medicare thinking more holistically about providing the support to the person living with dementia as well as their family caregiver. There are some challenges with the details of the system that don't always work easily, but we're dedicated to try to figure out how to crack that nut, just like every other creative problem we AAAs get.
And I would call my organization a reluctant guide participant organization because we are a participant in the model. We didn't want to be because we were hoping to find a health system partner to be the lead while we could provide all the wraparound support. But in our region, we couldn't. So we had to submit the application as the lead organization. So we are participating.
Great. Well, we're excited to see how it goes and the results of the demonstration in a couple of years. One quick question before we go from our Q&A is, how have you or have you not engaged people living in rural areas? And I guess that, there might be some other populations that are harder to reach. How have you done it? Have you done it and how has it gone, and any tips?
Well, I can be fast because I live in a metro area. There's not a lot of rural in my region, but what I will say is the example I gave earlier around the Georgia Memory Net is statewide and includes some telehealth opportunities as well, so that it's not just limited to metropolitan areas. So I think there are models that can really do the outreach in rural. I don't think that that's my strong suit since I'm in an urban area.
And we have tested many of our programs with rural partners, and I would say, and Missouri does some innovative things as a state. So partnering with our AAA network, partnering with in-home care providers, and working at the state level have helped us. And, the increasing use of telehealth have allowed us to serve throughout the state of Missouri.
And I'll just comment, we have some telehealth options, especially out of our VA medical center. It's still with this population in particular, you need someone to go out to the home and help with the equipment and the technical aspects. But the healthcare provider can be back at the central hub and interact that way, and it provides greater access to these services.
Great. Thank you, everyone, so much for your participation today and the excellent information you provided to all of the participants. We're glad that all of you were able to join us who signed on to the webinar. On this slide, you can see we have a QR code for the issue brief that highlights this topic of bridging healthcare and social services for people living with dementia and their caregivers. So feel free to link to that. And we will send out the recording and a link to this issue brief as well when the recording's available. We hope you'll join us again on July 28th at 2 p.m. Eastern when we have the webinar Building Community and Connections, Innovations in Adult Day Programming for People Living with Dementia. You can contact us at nadrc.webinars@rti.org with any questions. But for now, we'll say goodbye and have a wonderful afternoon. And thank you again to our wonderful panelists and moderator who helped us with this session today and did such a great job. We appreciate you. So take care, everyone, and have a great afternoon.